Good afternoon, everyone, and welcome to this new series of the Eco Confianza. This is our first session. I am Dr. Raquel Romero, and I'm going to be the facilitator for the sessions today. Again, thank you so much for joining this Communicating with Confianza. This is a Health Literacy Eco series. This ECHO is brought to you by Health Confianza team in collaboration with the UT Health San Antonio, Super Hub, the YMCA, at the South Central EHEC, and the University of Texas at Austin. Health Confianza is a community-wide health literacy program that aims to provide health literacy, education, training, and resources and workforce development for Behar County and the surrounding areas. Our team believes that health literacy is critical to transform health and achieving health equity for all. Sessions build upon each other, so we encourage to attend each session for enhance your learning experience. So I invite you and encourage you to come on the next sessions to see what we have been prepared for you. Now, for those that are new for the ECHO session, ECHO stands for Community Healthcare Outcomes. So we have different components in the ECHO. We have this welcome, and then we have the introductions, and then we have didactics and case presentation. The case is a real life scenarios that we invite you to think about and present it in the future sessions. And to ensure privacy, please note that no personal health information is allowed to disclose at any time during the session, just to protect privacy. So what is this personal health information? Well, it's the OBs, dates of birth, addresses, appointments. So to protect participants, we are not disclosing any information. Now, to assure and making sure that we record all the attendance, I would like to ask if you please enter your name and your last name and your email address and your affiliation in the chat. This is for our attendance records. And please remember to stay unmuted unless you are speaking, but I invite you to join us by video, particularly in discussion part of the session, so we have the opportunity to meet each other. So I would like to go and move to our introduction. So I would like to introduce our hub team. I would like to start with Dr. Rosenfeld.
Hi, good afternoon, everyone. I'm Jason Rosenfeld, Associate Professor in the Department of Medicine at UT Health San Antonio and co-director of the Health Confianza program. And I want to welcome you all. And if I haven't seen you yet this year, happy 2026.
Yeah, echoing that. Now we have Dr. Stone, who is also our lead specialist.
Hi, welcome everyone. So Melanie Stone, I'm here at UT San Antonio. I'm an assistant professor in our Department of Family and Community Medicine. So really happy to have you all join us today. I also direct our community engaged learning program, so I may have crossed paths with you out there in the community. Really excited to get us started, restarted for our ECHO series this spring. Thank you.
Thank you. Thank you so much. We also have Dr. Maria Fernandez Falcon. She's going to present the didactics for today. Would you please introduce yourself?
Yes, hello. I'm Maria Fernandez Falcon. I'm a pediatrician for one of our primary care clinics at UT San Antonio.
Thank you very much. As a part of our hub, we also have Dr. Adelita Cantu.
Good afternoon, everyone. Also, my name is Adelita Cantu, and I am a professor at UT San Antonio School of Nursing. Been working with Health Confianza for a number of years, and I'm sorry, I'll put my camera on now. I thought I did. And good to see everybody come back for this year. Happy to be here, and happy everyone's here.
Thank you so much. Thank you. Thank you. We also, as a part of our hub team, we have Corinne Reyes now. Ms. Corinne is going to present that case later, but would you please introduce yourself?
Hi, Corinne Reyes, YWCA San Antonio Chief Programming Officer.
Thank you. Thank you so much. And thank you all that attend our session today. And please enter your name and affiliation in the chat so we have this for our records, attendant records. And finally, I would like to say that ECHO is all teach, all learn environment. So we encourage to everyone to participate in our conversation today. On that, and no more from my end, let's go to the didactics, Dr. Fernandez Falcon, on your time. Thank you.
Yes, thank you so much for this invitation to talk about vaccine. Especially today, we're going to talk about why people say no to vaccinations and the way that we as healthcare providers and public health practitioners, we can help patients and our community. As a pediatrician, I recommend vaccines every single day of my professional life because I know that vaccines are a main preventing tool that protects patients, families, and our communities. My connection with vaccines started long before I became a pediatrician. When I was very young, I was bitten by a dog, so I had to receive rabies vaccines. And probably that act of vaccination saved my life. Next one. So this is the agenda that I'm going to go through. I will give you a brief introduction about importance of vaccination. Then I'm going to share with you the definition for vaccine hesitancy and discuss when this problem began. Later, I'm going to talk about drivers for vaccine refusal because they are going to help us to understand and create and support strategies to help our patients and communities. Next one. So why vaccination matters? And we all know that vaccines are a medical tool that help people to prevent severe infections and death. If you pay attention to this beautiful painting, that reflects the first act of vaccination. As you may remember, Dr. Jenner's almost 3 centuries ago implemented the first vaccination to the first patient, a child, and he inoculated a piece of a pistol for a person who donated from the right side of the painting with a mild disease called cowpox to protect him against a very deadly infection in that time that it was smallpox. Even though Dr. Jenner didn't know about immunology and antibody, he knew that that act of vaccination was going to protect that patient and then thousands of more. So now we know that vaccines activate our immune system to produce antibodies. Vaccinations as well as sanitation and clean water has become a foundation of public health strategies to make us live longer, so increase life expectancy. Also for this reason, the decision making to vaccinate or no is a very important topic. Actually, in 2019, the World Health Organization declared vaccine hesitancy as one of the most important threats for global health. Next one. So what vaccine hesitancy is and when this problem began. According to the World Health Organization, vaccination hesitancy is the refusal to vaccinate or the delay in acceptance despite the availability of vaccination services. So for example, people that they cannot afford vaccine and they don't have access to vaccines are not considered hesitants. This problem, as you may know, is not a new problem. It started a long time ago, actually, when vaccines were implemented. And there have been many historical drivers that led to vaccine hesitancy. If you see the cartoons on the upper right, in the upper left, these represent one of the main drivers for vaccine hesitancy. The lady in the center is getting vaccinated after all the people around her. And if you can pay attention, everybody around her is becoming like a monster. Pieces of animals are coming out of them. So that was one of the main drivers, the fear to become a different person, a monster, the fear to not following divine will or natural healing. Many other drivers included, for example, political drivers and, for example, government mandates on vaccines. So the other cartoon in black and white that you can see was made after smallpox vaccine mandates in the early 1800s by one of the first anti-vaccine movements with the goal to persuade parents not to vaccinate their kids to protect them against smallpox. Other drivers, for example, social drivers, were based on some medical and unethical experiments that you may know, and also other historical drivers over time has been based on risk-based, basically concerns about safety and vaccine ingredients. Next. So vaccine hesitancy, as you see, is not a new problem. It's an old problem. It's not black and white. It's very dynamic. It's like a spectrum. And I really like this graphic made or published by McDonald's in 2015 that shows the population that are in front of this vaccine decision maker. So most of the people are in the big group that accept all. On the other spectrum, you have a small group of people that refuses all vaccines. In the pediatric field, around 1 to 3% of families say no to all the vaccines. That is my personal experience as a pediatrician. And then you have a big group of people that they are hesitant, that we call fence sitters. They are ambivalent, and sometimes they accept vaccines, some of them, sometimes they refuse some of the vaccines, and in many times they delay. There are many examples. I have families that they say yes to all the mandatory vaccines, but no to flu vaccine and COVID-19 vaccine. I have families that they say yes to COVID-19 vaccines during the pandemic and no for the boosters. And now I have parents or families that they have concerns about hepatitis B vaccine for their babies, so they want to delay vaccination. So there are many examples about this type of situation. The main concern for these patients and families are information about vaccine efficacy, safety, and side effects. So the bad news is when they are seeking for information, they can be in front of misinformation and disinformation. The good news is they truly value recommendation for us from healthcare providers and public health practitioners. So this is a big group that we can really help. Next one. So what is vaccine disinformation and misinformation? So both are false information about vaccination, but while misinformation is not intentional, it's shared usually by people to people because they believe that that information is true, for example, among family members or friends. On the other hand, this information has a bad intention to cause harm in public health institution, and sometimes the goal is to generate profit, and usually is created and is spreading by influence groups, anti-vaccine activists, and more often now automatic accounts. There are many tactics that they can be used. Here I put only few ones. For example, evolving strong emotions like fear or anger, pushing conspiracy theories, or discrediting experts' opinions. Nowadays, misinformation and disinformation is easily available with social media and can spread very quickly. Next. So why people believe on misinformation and disinformation? And that is because all of us, we have biases, cognitive biases. So there are beliefs that our brain uses as a shortcut to take decisions, sometimes for our benefits and many times no. So I wanted to put a example, and we can review some of the common biases that are common on vaccine hesitancy. So imagine that this mom in the picture has two beautiful kids, and she's talking to a friend and say, "Oh, those vaccines are not here anymore. I don't know anybody who had tetanus or diphtheria or measles. So why I need to put my kids on having side effects from these shots? Their bodies are perfectly fine to fight against infections." So in this conversation, there are many cognitive biases. One of the common ones is called omission bias. So it's the belief that omitting or avoiding to act, in this case to vaccinate, because of the belief of side effects could be more negative, is more important that the commission act that is vaccinate. Optimistic bias is the belief that this is not going to happen to me. I don't see anybody with this type of infection, so it's not going to happen to me or my family. Availability bias is also the belief to pay more attention to the information that is truly available there. And because there is so much misinformation and disinformation, this is more relevant or more important that the information, the positive information about vaccine and the benefits. Naturalness bias is the belief that is more important the natural healing instead of a medicine, in this case, vaccines. And confirmation bias is the belief that some information that confirm pre-established thoughts are more important than be open to new information. This is a common bias in some people that still believe, for example, that MMR vaccine was related to autism. Now, for a long time, we have been having a lot of information, many papers that say that this is not true, but still is the belief of that pre-established thought. Next. So the World Health Organization create this vaccine decision-making framework model with the goal to help our communities and create good strategies to increase vaccine acceptance and help with vaccine hesitancy. Originally, this model was called 3C framework model, and then was modified. Now is called 5C framework model. So there are these main factors that truly affect our vaccine decision making. Confidence is one of the most important ones. As we talk, the belief on trust in vaccination, mostly efficacy and safety, the trust in a healthcare system and policymaker that government mandates about vaccines, for example. But this is not the only factor that really influence our decision to say yes or no to vaccines. Complacency is another very important factor, and is the perception of low risk of acquire vaccine preventable diseases, as we recently talked with this short case of that I just presented in the previous slide. Also low in knowledge awareness about the importance of vaccinations. The other factor is convenience, now called constraint, and is the availability or the affordability to be vaccinated. Very important factor when we need to create and implement vaccination programs to increase vaccination rates. The last two factors were added. One is called calculation, that is the engagement in having more information. So misinformation and disinformation play an important role in this factor. And last but not least, collective responsibility, the willingness to help others. The concept of community immunity is critical on vaccine decision making and programs that we can implement to improve vaccination acceptance. Next. So let's go to the last part of my conversation, and is how we as healthcare providers and public health practitioners, we can help our patients and communities. And education and trust are truly key components. Education about main concepts. Many people don't understand well, because they are complex concept of how vaccines works. What is an antigen? What are components of vaccine? What is an adjuvant or a preservative, etc. Also about how we keep vaccines safe, and we test for efficacy, explaining and provide education about what is a preclinical trials, what are the different type of trials, the importance of phase 4, that is the ongoing safety check that is done. Even vaccines are on vaccine schedule, they are ongoing check for basically efficacy and safety. And the concept again of community immunity is absolutely very important. Vaccines are not just for the individual, is to protect others. Very, very important concept. The way, the approach that we talk about vaccines when we are in one-on-one, with patients or with community members, is better to have a strong vaccine recommendations and use a presumptive approach. For example, I will say, Maria needs 3 vaccines today, instead of, do you want any vaccines for your child? That is a more participatory approach, but the presumptive is more effective. When patients or our community members, after this recommendation, are still in doubt, or they want to delay vaccination, then we need to move forward to another communication strategies that I'm going to discuss on the next slide. Next. So there are many communication strategies that we can use that they worked. One of them is called motivational interviewing or motivational dialogue. Is a approach that needs some training, but we can use elements of this approach to help our patients and communities. I know that many of you use some of these approaches to talk about this topic with patients and community members. So the first one is to listen with empathy, and sometimes it's challenging. As a healthcare provider, sometimes we have limited time to talk during visits with patients. Sometimes for our own personality, we tend to talk more to give recommendations, and we don't have the time or the training to listen first. Personally, for me, sometimes is difficult, and I try to think about, okay, give the patient the time to talk and listen with empathy. So that is a great opportunity for the patient to explain, or at least let us know their concerns. And the second step that is very important is to ask open-ending questions. Like, okay, tell me more about why today you don't want to get this particular vaccine. Tell me more. That's very, very important. Next. So after the patients or the community members express their concerns, then we have the opportunity to offer trusted information by asking permission to explain what we know, what evidence-based information teach us, or offer resources. We can offer our help and recommendation. They are very good resources that we can use and show our families to get evidence-based information. I will show you in few slides. Another approach is to explore reason for wanting to get vaccinated. This approach has been very useful during COVID-19 pandemic. So with this approach, people were able to take their decision without losing the autonomy and really exercise the options, the benefits of getting vaccinated. For example, visit family members, traveling, etc. Next one. So what we can do as an organizational level, I just talk about one-to-one conversation with patients or our community members, but at an organizational level, we can help our community in different ways. So one of the ways to do it is leading by example. This is one of the pictures I have when I got my first COVID-19 vaccine. I show my patients this. I usually do it when I get my flu shots. So that helps significantly out my patients to think about getting vaccinated or say yes to vaccines. I know that many of my colleagues use the same approach and posted in social media during pandemic. But pictures of us as examples to get it vaccinated first. Storytelling is also a very powerful approach. I talk to my patients sometimes, depend on the circumstance and the opportunity about treating patients in the past from vaccine preventable infections that now I don't see because of vaccinations. Another important approach is to go to the community, and community engagement and health literacy education is essential. This is a picture of one of the health clubs leading by Health Confianza community health workers. So they go to the community and they offer education that is easily understandable about health topics, including vaccinations. And the other approach as an organizational level is breaking down access to vaccines. Back to school vaccination events are always successful. because there are many, many people that they don't have access to vaccine or they cannot afford vaccines. Vaccines are expensive if you don't have health insurance, or they don't have time to go to the clinic, and they have this great opportunity to get vaccinated before school starts. Next. So in conclusion, we know that vaccine hesitancy is not a new problem, it's very old. It's not black and white, it's very dynamic, and it's complex but addressable. And we can help providing education, always with empathy and building trust. That's our key component. We as healthcare providers and public health practitioners are the experts, and we play a critical role, and we can offer trusted information to our patients and communities, and truly makes a difference. Next. So I really want to thank you again for this great opportunity to talk briefly about vaccines. These are the resources I usually use as a pediatrician. The World Health Organization website has beautiful visuals that you can see in my previous slides. They are in different languages that you can use to educate your patients and community members. Also, healthychildren.org is a great website created from the American Academy of Pediatrics for parents. It's in English and Spanish, and they have a big section about vaccines. You can also visit the webinars they have. The last one was about vaccination last week. Immunite.org is a website that is very useful for us as providers. They have material from us and also for patients. I usually print information when the families accept my recommendations to read more about vaccines. And there are also toolkits from the Pan American Health Organization for educators like all of us to learn more about, in this case, false information on vaccines. If you need more information or resources, please let me know. And thank you again for allowing me to talk about vaccines today.
Thank you very much, Dr. Fernandez Falcon, to help us to have a better understanding, a little bit more understanding on the roots of vaccine hesitancy, but not only that, but how we can help. I really like when you say live by example, show some pictures, some testimonies, and the work that Confianza has been doing, the community engagement, and be involved with the people around us. Thank you so much. Is there any question coming from our audience? In regards to this vaccine hesitation, you can unmute yourself, you can be in the camera, or you can put in the chat if you like. Or you can think on that and you can put it later. If that's easier, we want to be here. Oh, Dr. Cantu?
Yes, good afternoon again. And Dr. Fernandez Falcon, thank you so much for that presentation. I loved that you reached back into history. And you know, we've been here before. We've been here before. And it's always it's always good to recognize that, and we can learn from those lessons and just kind of interject what's going on right now. So thank you for that, and gives me some ideas on how to educate some of the nursing students on this, because we can all play a part in getting our community vaccinated. And I wanted to thank you for your presentation, and then Corinne, a shout out to you. Thank you for including the information about Onesimus. Is that, I'm not sure if I'm pronouncing the name correctly, but I did not know that, and so I will definitely share that as well. So thank you so much.
Thank you, Dr. Cantu, and very
Thank you,
good
Dr.
point.
Cantu.
Right, Dr. Fernandez Falcon, really, I really love the pictures, and also bringing us back, like this is new. I mean, we have been facing situations like this, so we can learn from our previous experience and learning what around us. But thank you so much. Well, if that's okay to you all, well,
But I
Dr.
just one more
Yes.
question if you have. I'm sorry,
Yeah.
I skipped over that. I was wondering, Dr. Fernandez Falcon, if you could, is there a particular patient interaction that you can recall in which there may have been some hesitancy and you saw over time where your continued communication and it was successful in getting them vaccinated? Maybe not at that visit, but maybe subsequent visits after that.
Oh, yes, yes. Thank you for asking me this. In my experience as a pediatrician, especially in the last couple of years, vaccine hesitancy has been a very common concern from my family. So every single week, I need to talk about these concerns. In my own personal experience, I have families that they say no to all the vaccines. I always talk, but at some point, they know my opinion. But the big group of families that they are the fence sitters, after talking and building trust, it really helps in my own experience. Sometimes it's hard to talk to new patients. So, for example, now one of the main concerns about hepatitis B vaccine for newborns. There is a lot of disinformation about this topic, these recommendations. So it's hard the first visit to talk and give the parents the opportunity to take the decision. Sometimes takes few visits. And because I'm so lucky to be able to see patients very often, so a pediatrician see a child 10 times during the first 3 years of life. So they have 10 well child visits during the first 3 years of life. So we go to see the doctor only once a year. So young kids, they need to see the pediatrician very often. So each opportunity is priceless. So with that opportunity, we'll build trust, and then the parents take the decision. Also, some websites like the World Health Organization and healthychildren.org are fantastic tools for parents to go and read and take the best decision without losing autonomy and feeling that we respect their own decision making. Thanks.
Really great point about building trust, and that just doesn't happen in one visit, right? And so that's a challenge.
Yes, completely agree with you. And we need to keep that in mind, because sometimes could be a big frustration, no helping families during the first visit. And I never lose the hope that I will help them. So try to keep offering resources and be open to answer questions and listen with empathy. That's very important. For me, sometimes it's very, very difficult. I'll be honest with you, but I try my best.
Thank you very much, Dr. Falcon. This is a very good answers that make us think, right? So how we can approach these situations. Any another comment or question before we move to the case?
I have a question about what your take is on the recent measles outbreaks in immigration detention centers. What do you think that is stemming from? Do you think that's lack of immunizations being administered due to vaccine hesitancy? Or do you think that that's coming because there's speculation both ways, right? There's speculation that it's vaccine hesitancy, and then you have people actually blaming immigrants themselves for bringing it from other countries. But it's my understanding that these immigrants are being rounded up on America, right? And put in these detention facilities to go back to other countries. So I don't really see how they would be bringing it from anywhere but here. Do you have any thoughts on that?
Yes, nowadays we have more and more outbreaks. Probably you remember the last outbreak we have last year in 2025 in West Texas. That outbreak was not brought by somebody who was coming from out of the country. That started from people here in the United States. We may have some outbreaks from people that are traveling from other countries and coming here, may happen, but the one that we have in Texas with more than 1,000 people with measles, kids and adults, and 2 children's death for this outbreak starting right here. And there are many factors that can influence the beginning of an outbreak. Remember the 5C framework model? So there are many factors that can influence on vaccine decision making and vaccine hesitancy. In that particular case, it was lack of access to vaccination started in a rural county. So the vaccination rate for measles was 62%, and community immunity for measles needs to have a 95% of more to be able to protect the community. So in that particular county with 62% of kids getting vaccinated against measles, the infection spread very quickly. Remember, measles is one of the most contagious infections in planet Earth. So that was one of the main reasons. And then there were an important group of families that they say no to vaccines. So a combination of different factors, misinformation and disinformation also combined and led to these outbreaks. So I think that education that we are doing today is absolutely essential to communicate our families and our community about the importance of vaccines, because there is a lot of misinformation about the negative effects of side effects, that there are misinformation, but I think that we need to have more information about the positive effect of vaccination. Thanks.
Well, I just want to add that my great-grandmother died of measles at the age of 37. My grandmother was not able to go to school to be a nurse because she had to raise her 2 brothers on the farm and live on the farm and even take care of her father because her mom died when she was 8 years old, you know? So this is a disease that was eradicated through diligence in making that vaccine and getting it to all Americans. And I find it really sad that something that affected my grandmother's life so severely is coming back and affecting families in America now and being blamed on anybody but the way that we're handling things. So anyways, thank you for just giving me your expert opinion on that. I really appreciate it.
Thank you. I'm sorry for your grandma. And in part, I'm doing this as a pediatrician because unfortunately also when I was a very young doctor, I have patients that they die from infection that we can easily prevent now. So I think that we need to keep educating and talking about the benefits of vaccine, because the thing is we don't see this infection because we vaccinate. And when we stop vaccinating, or we have a lot of families and people that unfortunately they receive this information and they don't vaccinate, then we have these big problems. Community immunity decrease, and then we started to see these infections. It's not a question of if we are going to see this infection, is the question of when we are going to see more outbreaks.
Yeah, that's so true. And thank you so much, Ms. Carpenter, for sharing your testimony, and I am so sorry to hear that. But as a Dr. Fernandez Falcon said, is through this knowledge, to these seeds that we're planting one by one, hopefully we can continue growing this not only for education but also in trust. And we all together can do that. That's what Health Confianza is here. We all can little by little, but we're gonna move into that direction. And that helps me to go and connect to Ms. Corinne, who is gonna present the case. But at this point, thank you everyone for sharing this, and keep sharing your comments for this session. Thank you. Corinne, on your time.
Thank you, everybody. It's been a really good conversation. This case I was not the main person that handled this case. Members of my team were the ones who kind of bore the brunt of a lot of this, and I kind of came in on the back end, on the repair end. But we had a patient who was seen by one of our mobile clinics, and they were advised that they needed to have their annual breast screening. That's what the patient heard. So when we called them to schedule the breast screening and we're reading the order, it was actually for a diagnostic mammogram with bilateral breast ultrasound because she was symptomatic at the time of her visit. Of course, her now hearing, I need this diagnostic, mammogram with bilateral breast ultrasound, which is like sounds super complicated and scary. When she was told she was going to get a screening mammogram, she immediately became very angry with our staff. Um, it took a while for us to get her to calm down and even agree to continue the conversation. Um, Her daughter even got on the line and was really mad at us as well. Um, you know, because of that miscommunication, it took probably like three or four of us to get the patient to calm down, listen to what we were saying, and agree to continue services. We also had to change a lot of workflow processes and um, involve people, in two different organizations just to get her calmed down because of that one, miscommunication. So that's our story, and I just wanted to present that, regarding clear communication and how things sound so differently when you just change a word from screening to diagnostic, and how that can like really make somebody feel very scared, and how many resources have to happen on the back end to repair that.
Thank you. Thank you, Ms. Corinne. Is there any question to the case and comment in that regard? Yes.
Just a comment. Thank you for sharing that story, Corinne. I think we can all learn from that as well. Two things. I think goes back to what Dr. Fernandez Falcon was talking about in building trust, right? That it took a lot of effort on your staff part, to start building that trust up again. And then also just for us always to remember that something like diagnostic, especially when you're talking about a breast issue with a breast exam. Although we've made so many advances in the care of cancer, that is still such an emotional word to hear. And, if we ever have to say that in the conversations, we do need to put some qualifiers there. Because again, we've made such wonderful strides in treatment, and cures and everything else. But it's just that word, or diagnostic and breast together, putting those words together. Yeah, I can see how that person could shut down other information that is also shared. So again, thank you for that, and a reminder to us all.
Thank you, Dr. Cantu. That was very insightful. Um, I know just there's some questions in the chat from the ECHO team, just for people to think about how can health systems better support providers and clearly explaining when and why a screening test becomes diagnostic. And that's a conversation we still need to figure out how to better have with our mobile clinic providers. And I want to, maybe just pose this, since there's a bunch of people with lots of great knowledge on this call. Even though our our team is very experienced and educated and with the patient population coming from our end as a community-based organization, when we're trying to tell the provider, hey, this happened when you were talking to our community members, sometimes it comes off, it has the capacity to come off as we're telling them how to do their job, and it's not always super well received. So, if people have had that experience, I'm interested to hear your thoughts on that.
Yes. Have you been having that experience? Someone can or would like to share? Because this is overwhelming. I'm just thinking and how this can be received if we were the patient, but how you can also say it if you are part of the healthcare team provider. Someone that have been experiencing that or have some ideas how that can be handled?
I personally, when it's a situation when it's difficult to explain to the patients, I use visuals that now we have easily accessible, if you have your computer, you can show pictures, or I can draw many times about what is going on. Or explain, for example, I do a lot of screening tests, like a developmental screening, and explain this is no a diagnosis. This is just to check if there is any concerns. And if there is a concern, it's always waited to move forward. So I think that is important. Also ask open questions. What are your concerns? Because sometimes we tend to talk a lot, and as you mentioned, the patients are like no existing. They cannot capture all the information. So make a pause and say, and I ask them to repeat. Also, what do you understand? Sometimes they come from the emergency room with a diagnosis and a lot of tests, and I can read that information, but I ask the patient, okay, tell me what happened at the emergency room. Tell me what the specialist told you. So that is a very important approach that for me personally works well.
Yeah. Thank you so much for sharing that because it's overwhelming. Any diagnosis is overwhelming. Any screening, any test, just going to the lab work is overwhelming for everybody. Dr. Rosenfeld, you have your hands up.
Yeah, I appreciate this case, Corinne, and I think the kind of patient or community level dialogue piece we've talked a lot about. We haven't kind of tackled the kind of professional to professional piece. I think that's an interesting one. And while I haven't experienced it in like necessarily this context, I think I spent a lot of time kind of thinking about how do we do this, in particular as like a public health professional who works within a school of medicine. I thought about it a lot. So I have like a question and a thought. One is like, what is the relationship that you have with the service provider, with the organization that is providing that service? Is it purely transactional? Because if it is, then it may be difficult to have that conversation. But if there's a long-term relationship there where you can actually engage in bi-directional input, right? So, and even starting it with, hey, we know that there's probably opportunities to improve this. Can you share with us your observations about like, clinical flow or patient intake? And then offer, we have some observations about kind of communication being our area of like expertise, like thinking about how you can frame it in like, this is your expertise. And it's not that the communication isn't, but, you can maybe own that as like a higher level of expertise and just say, this is where we want this relationship to go. But I think whenever you can kind of invite the conversation rather than the just the offering without it can sometimes be challenging. And then the last thing I'll share, and I may have shared this in a prior echo before, but this was taught to me by one of my former directors. What is it? Ugh, I just had it and I've lost it now. It's like I've noticed, I wonder, and like I worry that, and there's like an order you can do those. Like I've noticed this, I worry this, I wonder if, and like you can, because whenever you use those I statements, it is disarming to the person you're having the conversation with. All right, I'll stop there.
Well, this is very good, like a patient activation. Sometimes, like how we can engage them in the conversation. That reminds me that Dr. Rosenfield. Guadalupe, do you have a comment or
Yes,
question?
thank
Yes,
you.
thank you.
And I kind of missed I don't know if I missed this, but Corinne, is this something that your CHWs are present when the patients come in to the mobile unit? And I don't know if you're already doing this, but I was thinking that it would be good to incorporate a vocabulary sheet, right? That has just to give that with as you're welcoming and sign and registering people for their mammogram. I always think about this when we do screenings in community because a lot of the name of the test, the potential, results, we don't a lot of times explain that to our community members. So I think, doing a vocabulary sheet and tell them, you're going to get a call with your results, and this is what this means, and so that you can follow up, especially if they don't call you back, follow up and learn about your results. I don't know. I was just thinking that might be a good idea.
Oh, I like that idea. We are there, both like as they enter the clinic and as they exit the clinic. Um, but I think it would be an interesting idea to say, like, we could call you and say these things, and this is what these things mean. So there, I think is going back to Dr. Maria example about giving like the pictures, like the drawings or the illustrations, because I don't you can't remember everything. And if they, this would be a good thing to refer back to so they don't get freaked out on the back end.
Yeah, yes. Or I was doing patient navigation about 16 years ago, and we had one patient that was not following up because she was told you have stage 4, and in her mind was, 0 to 10, as we use with the pain scale. And so she was thinking that it was nothing serious, right? And it was stage 4 cancer. So I always remember that patient.
Ooh, that's a good example.
Very good. So very good strategy that you have been mentioned, the visuals and handouts, that the pictures, the language. Is there another one? Another, just in 1 minute, and another idea about how we can,
Well, I
yes.
think we've mentioned it, a few people have, but the technique of teach back, because that's really the only way you're going to know what that patient knows in terms of what action they're supposed to take. You can't, there's really no other way to know what they're thinking in their mind about what they're going to do. You have to ask them. So I think someone mentioned it earlier, but I just wanted to emphasize teach back.
The teaching back and the knowledge, yeah. Well, for interest of time and to protect everyone's time for the hour that we promised for this session, now we want to move to the summary of the recommendations, and that is Dr. Melanie Stone in charge for that.
Yeah, this has been such an interesting discussion. We started this ECHO series off very strongly. Thank you, Dr. Maria. She works closely with us in Health Confianza, so we know the great work that she does. I thought the very first thing you did of sharing your personal story of how you were bitten by a dog, and basically the only reason you're here with us today is thanks to a vaccine. And I think that's an important one that we can all use with people, because it's very, like, no one's going to have any controversy over someone getting a rabies vaccine. And so I think it's just, and it's a very impactful one. We appreciated your historical context, reminding us that vaccines have been around for almost 300 years, and there's always been issues and hesitations depending on what the climate is, what the social issues are. So reminding people, that these have been around for a very long time. Vaccines are not new technology. I think the tips that were provided, storytelling. I love storytelling. I think stories are very impactful, leading by example, making sure people, if they want to take a vaccine, that they have access to do so. And I just want to say, from the Health Confianza perspective, what we really do, we spend a lot of our time helping people realize none of us are here to tell people what to do. That is not our job. we we have to acknowledge that people are coming from their own personal contexts and situations. What we are here to do is give them the information that they need to make those decisions for themselves, and we're here to support that. And so even if you are fundamentally disagreeing with that person is saying or believing, it's so important to acknowledge their perspective and let them talk and let them tell you, and then you will be able to also provide the information that you need to. And then finally, the last thing I wanted to say is that with vaccines, it's the epitome of the quandrum of public health. When you see the benefits of public health and vaccines, you're not seeing anything. It's only when things are not going well that's when you see the measles outbreak and all the different COVID-19 outbreak. These are things that are happening because the behind the scenes work of public health hasn't been strengthened. And so it's hard work that we're doing. I appreciate all of you. And I think I'll end it on that. Thank you, Raquel.
Thank you, Dr. Sam, for these recommendations and for being our lead specialist. Thank you, Dr. Fernandez Falcon. That was a wonderful presentation. And to you that help us to have those sessions. Those sessions are possible because of you. Thank you for your attendance. And I invite you to think about cases that we can present in the future sessions. We can all learn. This is the heart of the eco sessions. It's all teach, all learn environment. I invite you to think about cases that we can present. And remember, each session is every 2 weeks. So our session next is going to be in February the 20th. And until then, thank you so much. Take care and you have a wonderful day. Thank you all for being with us.